And then I think the big area that would nice to see some improvement on is this chronic UTI or recurrent urinary tract infections. We haven't got all the answers. It can be difficult to treat.
Hi, welcome back to the channel. My name is Molly and today at Live UTI Free we're chatting with Dr. Nicholas Faure Walker. If you're new to our channel, be sure to check out the description below as we've linked to other resources that you might find helpful. Lastly, if you enjoy these videos, think they're important and want to support what we do, be sure to hit subscribe and tick the bell so you get notified when we post new videos. And other than that, we hope these videos provide the insights you need to take the next step on your UTI recovery journey. So, joining me today is Dr. Nicholas Faure Walker. Firstly, welcome and thank you for taking the time to share your experience.
Pleasure. Thanks, Molly. Thanks for having me.
Thank you. So to begin, could you tell us a little bit about your background and what led you into specialising in urology?
So I am a consultant neurological surgeon based in South London, primarily at Epsom Hospital and the NHS. I trained as a surgeon, and I think I sort of almost fell into urology really. I was quite attracted to a wide range of treatments and patients. So although I'm a surgeon, fellow of the Royal College of Surgeons by training, a lot of our treatment is with medications and non-surgical treatments. And we do a lot of our work in clinic. And so I was always quite attracted to that. Again, wide range of patients. I see young patients, old patients with a whole variety of disease. And I guess my own subspeciality, which is what we call female functional and neurological urology. I always quite enjoyed working with other specialities. So I work with a lot of gynecologists, neurologists, neurosurgeons, and generally we can be quite helpful.
Interesting. And following on from that, is there a particular area of urology that you like to focus on in your clinical work?
I guess so. I mean, from what I do, I primarily focus on what happens when the urological tract isn't working. So that can typically be symptoms like having to pass urine very often, finding it difficult to pass urine, passing urine at night, sometimes unfortunately urinary leakage, which can be very detrimental to quality of life, and aim to work out what the problem is. That can sometimes be a bit tricky, and then trying to find ways to treat it.
With that in mind then, what have you noticed about the kind of challenges patients with recurrent UTIs have typically been facing when they come to you?
Mm. I think a few things really. I think first of all, diagnosis. I think access to treatment as well is really quite hard. So we sometimes don't get the diagnosis right, or we miss it. The tests we have, which I'm sure you might want to ask me about, they don't always give a quick answer. They don't always give them the right answer. They don't rule or rule out things the whole time. I think the other problems that patients have is access to treatment. So certainly in the UK, you have to have a prescription from a doctor to get antibiotics most of the time. And a lot of patients find it very frustrating when they've clearly got symptoms of urinary tract infection. They know what treatment they need and they can't get access to their GP, or they might have to go to the emergency department, which can be really quite difficult.
Individuals in our community often find that there isn't a clear pathway for UTI treatment, and many of them feel stuck in where to look next. So many experience negative UTI test results despite having those clear symptoms. What's your take on the limitations of standard UTI testing?
Well, it's quite difficult. There's two things, I think. One's accuracy and the other's timing. So you may be familiar with that. Often if you have symptoms of urinary tract infection, dysuria, that's pain passing urine, increased frequency, suprapubic pain, you'll often have a urine dip test. So it's a strip is put into the urine, and this is really a screening test. So it looks at something called, well, the things we look at most carefully are the leukocyte esterase. So this is an enzyme produced by produced by your white cells. Those are inflammatory cells. And it really is just a marker that there's some inflammation happening in the bladder. What can sometimes happen, a lot of people, when they have urinary tract infections, they drink a lot more, so the urine can be more dilute and it doesn't necessarily pick it up. The other thing is nitrites. And the nitrites is a byproduct of certain gram-negative bacteria. So that's quite a lot of UTIs, things like E. coli, and they convert nitrates to nitrites. So it's an indication that some of these bacteria in the bladder. But it doesn't tell the whole story, because first of all, some bacteria won't reduce nitrates to nitrites, they won't show nitrites. And the other thing is you normally need to have urine that's been in the bladder for long enough for the nitrate nitrites to be produced. So it doesn't tell the whole thing. And we talk about leukocyte positive, nitrite positive, and they can give us a good idea whether you're going to culture some bacteria on a separate test, which I'll talk about in a moment. But again, they don't really give the whole picture, and they have to be interpreted with the patient's symptoms. So you need to get a history, know exactly what the patient's experiencing, and then you can interpret it, the dipstick test. The other test we have is the microscopy culture sensitivity. That's urine MCS. That's when we send a sample off. And then the bacteria is grown over a few days and is looked at under a microscope, and we try to identify any bacteria. And again, this will produce specific bacteria, but they won't necessarily grow if the patient's already taken antibiotics. And sometimes labs don't report the actual level of bacteria unless it's above a certain threshold. And a lot of these tests are based on a paper by a chap called Edward Cass from 1956. I mean, this has been challenged in the 1980s, and we haven't really got a better definition. But this test takes 3 days plus for the results to come back. So we're often treating infections blind. It doesn't really give us the whole answer.
So when someone comes to you with recurrent urinary symptoms, what type of testing do you typically use?
Okay, first thing, before any testing, I'll take a clear history. And what I'm interested in is when a patient gets an infection, what symptoms they get. And then I really want to know, do those symptoms get better with antibiotics? Because again, what makes it a bit difficult is that often patients are labeled with recurrent urinary tract infection diagnosis, but actually they've got some overactive bladder or they've got some stress incontinence, but it's all been attributed to infections, and trying to tease that out is quite important. Simple investigations, I would do a urine dip test. If it might give me an answer straight away, and then I normally send the urine off for culture as well. Simple things, and then other investigations we'd look at. Probably an ultrasound scan is quite useful. It often won't show anything abnormal, but we're looking whether there are any stones in the kidneys or whether the bladder's emptying completely. Again, quite helpful things. And occasionally I do a flow test. It's when you're actually in a clinic. We see how you pee into a machine that shows how fast your urine's coming out. And certainly with men, it can show whether you're obstructed. And with women, it can show whether there are any problems. And before I'd even do that, I'll probably do a clinical examination as well to look for women, to look for things like prolapse or estrogen status, whether there's something else that might be contributing to these symptoms. There are other tests you may have heard of, things like cystoscopies, which is a telescope that looks inside the bladder. I don't do this routinely. And the main reason we do this is to exclude bladder cancer. There's slightly rarer forms of bladder cancer that can certainly present in older patients. And certainly if a patient's reporting a chronic pain or blood in the urine or something about the history is not quite right, I'd also do a cystoscopy. But I certainly wouldn't do it as standard.
Okay, and how do you balance these test results with the patient's lived experience?
This is more of an art than a science, I'd say, actually, at this point. But it's these lived experience is the most important thing. That history, those details, the response to treatment, for me personally, are the most important things. What's useful about the tests, actually, is if you find an abnormality, you might be able to find something to correct that means that you can prevent infections in the future.
That leads to my next question. You have an interest in neurological urology. Could you tell us a little bit about that?
Yeah, sure. So, unfortunately, patients with neurological disease, things like spinal cord injuries, multiple sclerosis, or Parkinson's disease, their bladder function often isn't working effectively. It could be that their bladder's not contracting properly, or it could be they can't empty properly. And unfortunately, this can give them very severe lower urinary tract symptoms and can mean they get infections. And for a lot of patients, they're living pretty normal lives, but their bladder symptoms can really affect things and make life very, very difficult. So the treatment's a bit more invasive and often a little bit more needs to be done, but we can often get it much better.
Are there any typical neurological symptoms that individuals experience?
Well, normally patients come to me with a diagnosis. So, for instance, saw a couple of patients yesterday, and they've had a diagnosis of multiple sclerosis, and they've got bladder problems. And they're actually sent to me by their neurologists. It's quite rare that I will pick up the diagnosis myself. I've seen a couple of patients who are slightly older who had very bad overactive bladder symptoms, and it was quite obvious in clinic that they had Parkinson's disease. So I ask them a few questions about that, and then I would send them to a neurologist for a formal diagnosis.
We hear from many individuals who experience overlapping symptoms that may be linked to other conditions. From your perspective, how do you approach cases where recurrent UTIs may coexist with pelvic floor dysfunction or other conditions?
I think a lot of this comes back to history. asking about those symptoms, asking about patients if they've got risk factors for those other things. And I certainly see a lot of women around perimenopause and recently into menopause, and important to pick up those things as we go through. I mean, I guess how do I? A lot of those things are discernible in a history. There aren't necessarily tests that do it. Yes, of course, if you're culturing regular bacteria on cultures and that would be in urinary tract infections, we can prove you've got overactive bladder with urodynamics. But again, a lot of it comes back to what the patient tells me.
And when you've identified the cause of someone's symptoms, how do you typically approach the treatment, especially for those who have had long, complex histories with UTIs?
Mm. I think for Jenny, if I was just seeing someone for the first time, then we normally try and start off with simple non-medical interventions. So actually for things like UTIs, sensible fluid management, I normally say above 1.5 litres, but you don't need more than 3 litres unless you're exercising. And that's just it's a simple thing that can be done. Then after that, if these things aren't working, we can talk about medical interventions. And typically for recurrent UTIs, I try and use non-antibiotic treatments first, and then we can use antibiotics if necessary. And similar with any other symptoms, we normally try to use non-medical treatments first, then we try to use medication, so tablets. And if those things don't work, then surgical options after that. I think sometimes when I see a patient who's had a lot of investigations, seen a lot of people, I often go back to the beginning. I have had a few patients where I've just stopped all their treatment, started from the beginning, gone through the tests again, and worked out exactly what the diagnosis is.
Many people in our community are interested in the non-antibiotic options, especially those with recurrent symptoms, having taken lots of antibiotics in the past. Could you tell us a little bit about your experience with UTI and vaccines?
Vaccine. Okay. A few vaccines around at the moment. We have the Urimmune vaccine, which is now prescribed in the UK. That's a sublingual spray taken twice a day. We normally give it for 3 months. Has been a couple of trials showing this is effective, and I've had a couple of patients I've had quite a few patients who are very happy with the results of it. There's the Expect9V vaccine, which is an injection there's a trial that I was involved with earlier on. That's a single injection, but that's more to prevent invasive E. coli infections rather than just specifically UTIs. There are a couple of more that have been trialled on the market. Slight problem having in the UK, I think, is that the hospital treatment pathways, they tend to be quite far down the line, after you've failed low-dose antibiotics and you've tried lots of other things, when actually their position is probably earlier on in the pathway. But certainly I've seen some good successes with it, and very, very few side effects.
Looking ahead now, what changes or innovations in UTI care do you think would make the biggest difference for patients?
I think widespread education for GPs, doctors, urologists, people looking after UTIs to understand a bit better. I think diagnostics would be helpful. If we could do quick tests where we can see whether there is inflammation, whether there are bacteria there, and what they are, and what those bacteria are sensitive to, then you would be able to get the right antibiotics to the right people at the right time. But that is going to be quite challenging. And also, I'd like to see a couple of trials looking at the ideal length of antibiotic treatment. I'm not sure where the evidence for the 3-day treatment for a lot of women is, but I certainly tend to give women 7 days, I think, of antibiotics. They do have an acute urinary tract infection. That's based on experience. I haven't got that much evidence, but I've certainly seen women who I think need more than 3 days of antibiotics for their infections. And then I think the big area that would be nice to see some improvement on is this chronic UTI or recurrent urinary tract infections. We haven't got all the answers. It can be difficult to treat, but I'm sure there are some more things we could do.
I think that's some great points. We hear from a lot of individuals in our community about the length of antibiotics and finding that 3 days doesn't necessarily help treat the infection. So I think that's important. And finally, for individuals who are currently managing recurrent UTIs, what would you want them to know or keep in mind as they navigate their care?
First of all, we know it can be really difficult. You can be a very healthy individual living very normally, and this is very, very difficult for you to manage, and we know it's difficult. Diagnosis can be difficult, and the treatment often doesn't work. But please know that we normally find something that helps. I'd say every patient is an individual. There's lots of different treatments out there, and there's normally one treatment or a combination thereof that can help you, but it might not be the first one.
Thank you. What is the best way for patients to reach out to your practice or book an appointment?
Well, in the local area, referred by your GP for NHS. If not, I have a private secretary, which I can provide the details of. But Mr Faure Walker, PA at hcahealthcare.co.uk, but I'll pass that to you if you need it.
Thank you. We really appreciate you taking the time to talk to our community. I'll add the details of your contact information in the description for anyone who would like further details. Thank you.
Well, thank you very much. It's a pleasure to be here. Thank you.
Thanks so much for watching. I hope you found this video helpful. You're always welcome to reach out to us for more information about clinicians who specialise in recurrent and chronic UTI. Our contact is in the description. If you'd like to learn more about this or related topics, be sure to check out our other videos or head over to liveuti3.com for other articles on recurrent UTI treatment options. Of course, if you like what we're doing on this channel, make sure to hit the subscribe button here on YouTube and tick the bell so you get notifications about future videos. Thanks so much for joining us for our Clinician Insights series. If you have suggestions for who we should interview next, be sure to drop us a comment.